Welcome to Emergency Insights. I'm James Carter. Today, we'll discuss a critical topic that directly impacts how we manage cardiac arrest, the reliability, or rather the unreliability of manual pulse checks. Despite being part of the standard ACLS algorithm, the traditional method of using our fingers to assess for a pulse is deeply flawed, particularly in the context of cardiac arrest. Let's face it, even under ideal conditions, palpating a pulse in a hypotensive patient is difficult. When the patient is in cardiac arrest, it becomes nearly impossible. Multiple studies have shown that manual pulse checks are not reliable indicators of return of spontaneous circulation, or ROSC. The truth is, our fingers can lie to us. They can give us a false sense of security or lead us to continue compressions unnecessarily, or worse, stop them prematurely. So what should we be doing instead? Whenever possible, we should rely on more objective tools. Ultrasound and arterial lines are far more accurate in determining whether circulation has returned. Point-of-care ultrasound can quickly show cardiac activity or movement of blood through major vessels, and arterial lines provide a continuous, real-time blood pressure measurement that is invaluable during resuscitation. Now, let's talk about End-Tidal CO2. This is a useful adjunct. It can give us indirect clues about perfusion and ventilation, and a sudden rise in EtCO₂ may suggest ROSC. However, it should never replace ultrasound or arterial lines. It's a piece of the puzzle, not the entire picture. A common question we encounter is, when we do have an arterial line or ultrasound, what's the threshold to stop chest compressions? Here's where things get tricky. There's no universally agreed upon number, no solid evidence-based cutoff. But in the absence of hard guidelines, a mean arterial pressure greater than 50 or a systolic blood pressure greater than 60 is a reasonable working threshold. Below these values, it's unlikely the brain is being adequately perfused and chest compressions should be resumed. So where does this leave us? It leaves us with a need to modernize our resuscitation practice. We must acknowledge the limitations of manual pulse checks and embrace the more reliable technologies available to us. Use your tools, trust your data, and always ask yourself, are we perfusing the brain? That's it for today's episode. Thank you for joining me on Emergency Insights. I'm James Carter. Stay sharp, stay curious, and as always, stay committed to excellence in emergency care.